Okay, moving.
Let's give it 1 or 2 more minutes for people to join. Apologize, folks. We were having some technical difficulties in the background, so apologies for that, but thank you all for joining. I am going to give it just one more time for people to join, and let me start. Okay, it is recording. Everything is set. Again, thank you all for joining, and apologies for the technical difficulties that we were having on the background. But we are here. We are super excited to have you all here with us. And most importantly, we are very, very excited for the conversation that we are about to have. First of all, I would like to mention that this webinar is part of the Gay Men of Color Fellowship. The fellowship is a program under the treatment division where we recruit advocates from the community, just to make sure that we leverage the work that they're doing, develop their skills, and really build community. We envision a movement that is led by those that are disproportionately affected by HIV. And that's why we have a program that is designed around gay, bi, queer men of color. And before we continue, shameless plug, I want to mention that if you want to learn more about, if you want to access more resources around HIV treatment, prevention, stigma, or where to access services, please make sure that you go to the CDC Let's Stop HIV Together website to find more resources. I am going to be sharing some links shortly, but wanted to mention that there you can find toolkits already with captions that you may use. You may use it for specific populations. You may use it for people to get tested and access testing at their home. It's really accessible, and I will be sharing those links soon as we start this conversation. But now, without further ado, I wanted to introduce you to Edgar Meras. Edgar is one of the Gay Men of Color Fellows and has been leading conversations about neurodiversity and HIV. And I am really, really excited to have him present as a person with the lived experience and as a person that is really passionate about making sure that HIV services are accessible to all. Again, Edgar, thank you so much for your time. Thank you so much for preparing this presentation. And I will pass it over to you. For the attendees, if you have any questions, you may use the Q&A box, and we will have a Q&A session at the end of today's webinar. So thank you all for coming, and the floor is yours, Edgar.
Thank you, Damian. Thank you for having me. It's a pleasure to be here. I didn't expect to be doing these workshops, these trainings. It's all your fault, honestly. But I love doing this. I think it's what I've was supposed to be doing a long time ago. And now I'm doing it on a larger scale. I'm doing it at conferences, I'm doing it virtually. And like you said, I'm lived experience, I'm able to kind of talk about my life. I'm able to kind of use my career and my background as a professional now, and bridge those things to start a movement from an authentic perspective. So I'm really happy that you gave me this opportunity, and
Of course.
a lot of
Thank you.
people are pouring into
I
this.
don't think we are having this conversation enough. So I am happy to give the platform to you for you to present it for people to learn more, and hopefully they will gather information on how to adapt services. And that's what the Q&A is for. So again, use the Q&A box and send us your questions. But of course, thank you so much, Edgar.
Thank you. Okay, so So should I just get started with the presentation? Okay, so let me see.
And I can also share mine if you need me to.
Yeah, I might need you to help me with that.
Okay. Yes.
Actually,
Let me.
I think I got it.
Okay. There you go.
Perfect. So, does everybody see that correctly?
Yes. Yeah.
Okay, awesome. So today's presentation, I adapted it a little bit to I've been doing this about a Latino perspective. I've done it about the perspective of people of color, Black and Brown, because I'm from Chicago, and I think that in Chicago, I'm privileged to be around a rich uh, community of Black and Brown folks that that I think that I get to actually speak from an authentic perspective, and I think that I have been able to tailor my presentations in a way um, that kind of tell a certain message. Last time that I did a Latino perspective was at the NALA conference, but this time I wanted to do a collective effort because I think that I don't want to be doing advocacy by myself. I think that you don't always have to be going through, you don't always have to be the one with the diagnosis to be advocating for people with that condition. And so that's what I'm hoping to advocate for today and emphasize on, which is the term of neurodiversity, um, which is the marriage of both people who are neurodivergent and people who are not. And I'm going to talk a little bit about that in the presentation, and then a little bit about HIV equity um, and ending the HIV epidemic, because a lot of times people who are neurodivergent are left out of conversations about sex, conversations about HIV and prevention, people who, and then the whole continuum, honestly, treatment as prevention and treatment for folks who have HIV. So, yeah, so let's just get into it. So a little overview. I have some terms to know, neurodivergent background, some cultural consideration because I am first generation Latino, and some nuanced care and treatment barriers, medical mistrust. I do work in public health. Before this, I was working as a therapist. I have a behavioral health background. I studied psychology. So I think I like to speak on the ins and outs as a patient, but then also, um, as a provider. And then HIV, how it ties into it, and then guidance, capacity, and the future, how we can actually make an impact, how we can start, a call of action. I think I like to always leave with um, there's a lot of things that we could have already done. And this isn't to blame anybody. unless you already know you're doing it. And there's a lot of unintentional harm that's done. So yeah, let's just, if there's a way that we can look into that blind spot, to help people that are suffering in silence oftentimes, let's do it. So there's a little picture of me. So my pronouns are he, él, because I'm bilingual, and I'm from Chicago, originally from LA. But I grew up here in Chicago, South Side, and I was recently promoted to training and development specialist, which is pretty cool. I used to actually be the lead for the SAMHSA program here, which is I used to do interventions with substance use and mental health program, which is really cool. I used to go into rehabs, um, and in there I would, talk about, mental health and substance use, but I would throw in there the topic about sex, um, which, oftentimes it was like middle-aged men, um, and, being a person of color, I never had to talk. They didn't either. Um, And so it was oftentimes a conversation that at first was uncomfortable, but it had to happen for prevention, for harm reduction, um, and because we all deserve it. And so, yeah, I think SAMHSA was definitely something that was fulfilling for my career, and it felt good. Um, I love SAMHSA. And then my motivation is y'all, and then having the opportunity to contribute and to make the lives of people suffering in silence just a little easier. There was a lot of times that I didn't know how to ask for help, and people were helping me, and that is, that's deep. Not knowing what was going on, and then also kind of building an identity of you shouldn't be asking for help because this is who you are, um, and then still receiving help anyways. So I think, yeah, I think there's a lot of people out there that will never be able to ask for it because some people don't get diagnosed. So we shouldn't have to expect people to wave a diagnosis card, to just receive extra patience and kindness. So that's my motivation. Okay. The learning objectives. Okay, so let's recognize inclusivity and nuances. Identify key aspects in inclusivity when serving neurodivergent individuals in HIV prevention. This is important because I think we shouldn't always assume that everybody's atypical. I mean, we shouldn't assume that everybody is neurotypical, which means we shouldn't assume that everybody does not have a condition that impacts their way of living, and understand systemic stigma, explore how systemic stigma and structural barriers impact neurodivergent access to HIV prevention services. There's a lot of things that are underlining um, hidden barriers for sure. And I think even just like the way that we are trained as testers could sometimes be a hindrance to building rapport. And I can explain that a little bit later. Um, and then promote inclusive practices, learn to implement inclusive strategies and better support neurodivergent individuals in LGBT and HIV prevention spaces. Um, yeah, I think sex ed was never made for people in special ed. And then a lot of people of color, a lot of times they're late diagnosed or don't get diagnosed. And so special ed was something that they never really got a chance to be part of. And so sex ed and HIV prevention, it doesn't really oftentimes fall into place. So there's a lot of things that um, need to that need work, and it could be polished. And I think there's a lot of mentions that I'm gonna emphasize in this presentation. Um, and I think oftentimes people assume that people who are like autistic, I'm autistic myself, that people who are autistic don't really have sex, who don't really have, who are asexual. Oftentimes I've heard that. And so, yeah, I think that there's a lot of stigma that leads to why people wouldn't pour into this community. So yeah, it's part of ending the HIV epidemic. Um, and so I think that that's why we should talk about it. And it's also part of equity, not expecting the same standards or the same practices to be conducted if you're going to be acknowledging that this is a different community. Okay, so let's talk about some terms. So neurodivergent, while it's not a diagnosis per se, it's a term that derived from the community, that describes, it's a description that describes, I wrote a note here, that describes like how we perceive, behave, interact, and understand the world, and from the angle of, neurologically, being altered from the rest of society. So a term that describes individuals' neurological development and functioning are atypical. And on the other side, from this Venn diagram that I created, neurotypical, a term used to describe individuals whose neurological development and functions are consistent with a considered typical from society. So yeah, just it's another term to just describe normal per se, neurologically standard. And so, but neurodiversity is the word that I used in my title because I think a lot of times we focus on just the word neurodivergent. But I think when we consider neurodiversity, which is a concept that regards individuals with differences in brain function and behavioral traits as part of a normal variation in human population. So when we don't consider neurodivergent people for how much they bring to the table, but rather a different type of person, not always valuing people for strengths and weaknesses. They should be seen as a neurotype. And so when we start seeing people as neurotypes, that is when we start seeing people as a variation of a person. And so when we start normalizing variations of people, there's less competition, and the neurodiversity piece, that honestly allows for a room to exist where a person who's neurodivergent to ask for things where they don't feel like they are asking for too much. And then also the people who are not maybe needing those things won't ever feel like that person's getting special privileges. There's a lot of stigma on both sides, and there's a lot of like internalized ableism which is something that I'm going to talk about in this presentation. But neurodiversity is, yeah, there should always be a marriage, because it shouldn't be about strengths and weaknesses. We shouldn't be valuing people like that, because even people without conditions have strengths and weaknesses. Okay, hidden disabilities. Oop, second. Hidden disabilities is a term that a term that I chose to highlight, because I think oftentimes this is one of those that will get ignored, and this one can oftentimes get dismissed. This one could get, there's discrimination for this one, oftentimes. A disability, condition, or illness that is not immediate, that is not immediately apparent to others. It may also be called non-apparent disability, invisible disability. Examples include chronic pain, mental health disorders, autism, learning disability, and sensory impairment. So yeah, I think autism is a good example of that one, and chronic pain as well. I think chronic pain is one of those things where, like, at times you may need a cane, or at times you may need a wheelchair. And if they see you be more physical at times, they may start building a joke on that, and that may be like a running joke in the office, just to start being, it may be lighthearted, but in all honesty, that just leads to people not feeling safe, honestly. But yeah, hidden disabilities, if it's hidden, it's going to be less respected, honestly. And I know that because I feel it. Ableism, and it's because of ableism, the discrimination or prejudice against individuals with disabilities, which results in social, physical, and systemic barriers that limit opportunities for participation and equality in society. Now, this is really important, because I think when we talk about ableism, when we aren't respecting people for their actual disabilities, people will then have internalized ableism, and they won't ask for help as much down the line. It'll change the way that they respect themselves. It'll change it ultimately just makes their life so much harder. But also it sometimes alters the way that they access resources. And it could impact the way that they, view their outcome, or what they see as deserving for them. Acquired neurodivergence. I loved putting this one on here just because I think a lot of times people think that neurodivergence is something that you're born with. And honestly, neurodivergence is oftentimes not something that you're born with. There's a lot of reasons why neurodivergence would be acquired. So acquired neurodivergence refers to the onset of cognitive or neurological differences after birth, often resulting from brain injury, trauma, illness, or environmental exposure, distinguishing it from neurodivergence present from birth. So yeah, I think this could happen from emotional turmoil, um, blending into a pure normal. Um, I think if you are in an abusive household, if you are in an abusive relationship, mentally and emotionally exhausting environment, over time, as a safety mechanism, you know, masking these behaviors, you can develop a neurodivergence just by trying to feel safe. Okay. Just like I mentioned about, actually, let me go back. About ableism, I wanted to mention that ableism is really important to talk about because while ableism isn't mentioned as a syndemic, it does function as a social determinant of health. And that's why I emphasize this at, in presentations as something that people in public health should be concerned about. It's not just something that it hurts someone's feelings, but it really impacts how people seek resources, and it impacts people's help-seeking behaviors. An estimated of 15 to 20% of global population is neurodivergent. Only 17% of people with disabilities were born with their disabilities. So, like I mentioned, acquired neurodivergence, that's at 17% is a pretty low percentage. Acquired neurodivergence often results from brain injury, trauma, illness, or environmental exposure. Kind of mentioned that in the previous one. Symptoms are very interesting because they manifest differently based off of your environment, based off of sometimes how late you've been diagnosed, if you've ever been diagnosed, and if you've gotten support after your diagnosis, and things like that. So for some background, I broke down symptoms based off of diagnosis. For diagnosis, people who have a diagnosis, symptoms may look like difficulties with social communication, sensory processing issues, and repetitive behaviors. Now, this is very interesting because, I think that sometimes when people who are diagnosed, they oftentimes do get privileged to things like special education, knowing concepts like neurodivergent, things like stimming, fidget, or even knowing like sensory room, or even knowing how to ask for things or communicate your needs. And so I think it's very interesting to see these kind of symptoms as common for people who are diagnosed. And it's important to maybe note these for when you do have clients that come in versus people who are, not diagnosed. Because, oftentimes when we do get training for doing outreach and stuff like that, they were not going to give you trainings on people who are neurodivergent, and that's just the T. And then for people who are undiagnosed, which is oftentimes, people who are people of color, that's just the tough reality. A lot of people that I know that were late diagnosed or still haven't been diagnosed, but are trying to, establish that. are people of color. And so it's a little harder for people of color to get diagnosed for many reasons. I can talk a little bit about that later. Um, People that are undiagnosed, their individuals may experience anxiety, depression, and may be misdiagnosed due to masking or lack of access to diagnosis. Um, and that's very easy to understand because when you have to deal with being undiagnosed, it just becomes more difficult to meet criteria over time. If you start developing anxiety and depression, um, that's a mental illness, where the person may have had a developmental disorder like ADHD or autism. Um, that may not be something that gets assessed because the person has already developed anxiety or behavioral issues. Um, and that's unfair to the person. Um, and so these are things to consider. Um, because people of color oftentimes don't get diagnosed, get misdiagnosed or late diagnosed. Um, we oftentimes get labeled with things like anxiety, depression. Um, Even if that is true, um, that doesn't mean that we shouldn't have ever gotten assessed for other conditions. And that's all I'm saying. Everybody should be getting assessed. And unfortunately, there are certain conditions that are more difficult to get diagnosed for if you develop mental illnesses, substance use disorder, and even until 2013, you couldn't have autism and ADHD at the same time. Um, so, you know, autism oftentimes was portrayed as, it wasn't modeled as a, as like, it wasn't represented as a person of color. And so when we consider how many people out there were diagnosed who have ADHD and autism, who only got ADHD before the year of 2013, that means that they couldn't have gotten a diagnosis for autism because the system didn't allow them. A system that was maybe that's for a different presentation, but I think that um, there's a lot of things that are weaponized against people of color. Um, and so I think it's important to know that. And so, yeah. Employment and stigma. A significant number of neurodivergent individuals face barriers to stable employment due to bias, lack of accommodations, and inflexible work environment. Um, yeah, so unfortunately, only about 15 to 20% of people who are autistic um, have a full-time job. Um, that number, I'm sure it fluctuates, but that's pretty scary. Um, I feel blessed to definitely have a job. Um, I definitely feel like I should have gotten fired several times. And I burned a lot of bridges several times leading up to this. Um, Before I got diagnosed, because I didn't get diagnosed until I was 27. Um, but before this, I burned a lot of bridges. Um, And I think that that wasn't entirely my fault. And so I think that, yeah, I think that if the system could work on, being a little bit more flexible and offering a little bit more accommodations, I think that that would allow more people to just pay their bills. And I also saw another study that was talking about how a lot of people who are experiencing homelessness, if they could get evaluated, assessed, you know, many of them would be neurodivergent. And so it's a tough thing to consider. How many of them, if gotten the support, could be employed, could just, be on track. I've been homeless several times. I've been fired. Never because I quit before that happened, but I think I've been unemployed several times. I've been out of a job several times. I've been out of a home several times. And yeah, I don't want to make this about like woe is me, but I definitely think that uh yeah, I think impulsivity and especially in ADHD is linked with higher risks of injury and legal issues and substance use. This is really important to consider because I think that when we consider people who are neurodivergent, um, we we shouldn't always just consider them. We shouldn't only consider autism. I think people who are neurodivergent, it could be many conditions, OCD, and oftentimes it's more than just one condition. Um, you know, I started doing drugs when I was like 14, um, and I say that proudly because I don't have shame anymore. That saved my life at one point. That was harm reduction. Um, and if if I was judged based off of how my sweater smelled that day at the doctor's office, um, that would have, impacted, me getting services. So I think sometimes you have to recognize that like people do what they got to do just to get to their appointment, just to mellow out the sounds, and they don't always have their answers. They don't always have a diagnosis. Um, but I made it that day. Um, but yeah.
And Edgar, there's a question in the Q&A box. I don't know if you can see it, and the reason that I bring it up is because it was part of what you were just discussing. It's a question from Cesar. It says, "Can you talk a little more about how to get diagnosed? That it is more often now for adults looking for the diagnose." And he's also bringing up the kind of the discourse around the political discourse from around Tylenol specifically and all of the things that are happening not only for HIV but specifically for people who are autistic.
Yeah, I think it's very difficult to get diagnosed. It took me the first time I tried to get, I mean, well, my next slide actually talks about diagnosis. But I think I didn't get diagnosed until I was like way, way, way later. Um, and I think I didn't get diagnosed because I mean, I did get diagnosed, but I got referred to an autism specialist through my psychiatrist. Um, So I got diagnosed with ADHD when I was like 21. Um, and then they referred me like 6 years later. Um, and so it took a while. It definitely like and then once I got to the first assessment, it it didn't go as planned. I had to get another assessment. Um, and so my second evaluation, it was like a two-part session. It ended up being like over 6 hours. It was like a whole bunch of like a whole bunch of like batteries. They're like different tests that I had to do. Um, but it was really expensive. I'm glad that I had insurance at that time. Um, I I it they make it way harder than it should be. Um, and I hate saying that. Um, it's like I felt like I got lucky that I got diagnosed. Um, and and so yeah, I think they kind of just like explained to me, and once I got diagnosed, like it wasn't like easy for me because I think a lot of times I was feeling like a lot of grieving. It wasn't like I got all my answers. Um, it was more of just like I was pissed at why I didn't get the support I should have, and things like that. And then also the Tylenol thing. I think it's really hard to see the political climate right now, and seeing the government um, use autism as a distraction um, for because I think there's a lot of things happening with the ICE raids, and it's a distraction. There's a lot of progress that we've made with autism, and so this is just a distraction. The Tylenol thing, like we already know, that it has nothing to do with it. And so I think that like it just sucks that people are kind of like feeding into it and then also making memes of it. It makes my life harder. It makes me turning this into a movement. It kind of minimizes it, dismisses it. Um, it eats away at the snowball. Um, but were there any other questions?
So far, no. So far, that was the only question.
Okay, cool. I'll try to speed it up a little bit. Okay, so cultural considerations. Okay, so when we are taught to hold it in and not fall apart, to be okay even when we aren't, what would it look like to redefine strength in our community in a way that includes neurodivergent and emotional expression? Um, Actually, let me just get straight to the second one because I think first for time, um, I think being diagnosed late was I think very it was heavily because I am first generation. And I'm a product of parents that immigrated to this country, and they were trying their best, and so I try to understand and empathize, and I love my parents, and so I I don't have any resentment, and so I pose this question to try to help everybody understand a little bit about like the complexity and the nuances about what sometimes goes on with why someone may not get diagnosed. My undocumented mother was afraid to get me diagnosed, or even evaluated out of fear of losing custody. In what other ways has an undocumented immigration status impacted your ability to acknowledge and address health challenges, especially those that are not physical? And that's not to say that that's not to say like physical and non-physical are like, one's better than the other. I think it's more just like I think it's more so that I think it's more of like seeking help. And so yeah, I think I'm kind of curious if there's anybody that would like if there's anybody that would like to touch on this one.
Please feel free to use the chat or the Q&A box to engage in the conversation. So far, there are no comments, Edgar.
Okay, cool. Yeah, and I think this actually impacted me very heavily because it it made me um every time that I was in school and I wanted to it really made me it impacted my way of like seeking help from teachers. Um if I was ever sick, I would still go to school. If I was ever sick, I would only go if it was an emergency. Um and so I think that we have to consider um, how, our culture sometimes doesn't allow us to get the support that we deserve um, because sometimes we're scared. Um, Sometimes we go through things that um, make us feel like we are going to impact our the safety of our family. And as a Latino, I definitely did not want to be put in a group home. Where my mom comes from, that was a reality. People who are with disabilities, they do get put into homes, in group homes and stuff like that. And so they have very limited knowledge of that. So something to consider. Um, I didn't have
Edgar,
to.
I'm sorry to interrupt. We have three comments on the chat. I don't know if you can see them. One is from Cora. She's mentioning overall access to healthcare as undocumented, and that agrees, and even less for mental health specifically. Carlos also mentioned I was diagnosed with ADHD in my late 20s, and it was because of therapy that I was able to understand myself better. And Cesar mentions that the cultural background also could impact the access to this diagnosis, especially with the lack of normalization of taking care of mental health in the Latino community.
Yeah. And Jeffrey, I did see, can you tell us more about different stages of autism? Yeah, I wish that I was like an autism expert. Um, being late diagnosed, like I'm still learning about it myself. And for like 4 or 5 years, and then the pandemic, um, like I was grieving and trying to accept this. So I'm still learning a lot about autism myself, and being on the spectrum. I'm just gonna be honest. So I don't consider myself an autism expert. Um, But I do think that these symptoms I've had them my whole life. And so I'm trying to unmask, um, and I'm trying to learn how to stim comfortably, and things like that. Um, and you know, and so I think I'm trying to learn about it as much as possible, so that I don't ignore the things and the needs anymore, and advocate for other people to stop doing it too. Um, so just for the sake of time, let me just try to touch a little bit more. Nuanced care and treatment, treatment barriers. Um, you know, treatment barriers, rejection sensitivity, dysphoria. Um, this is an important thing to consider. It's not just a simple rejection. It's actually when people who are neurodivergent oftentimes can experience rejection at a deeper level that can feel like emotional, physical, actual physical pain. Um, and that could determine if they even come back to the office. Um, and and I think hidden disabilities pose a risk in HIV prevention. Um, Providers should avoid over resilience and verbal communication. I mentioned this earlier, like we can't expect people to always wave a diagnosis card. We can't expect everybody to coming in to be neurotypical. That shouldn't be an assumption. Um, there's a lot of hidden disabilities. There's a lot of people with chronic illnesses. There's a lot of people with substance use disorder that are just, trying to get by. Um, Substance use disorder oftentimes is developed when you don't know what's going on. And so, that happened to me. And I think that's something to consider. That may be an underlying condition that could be impacting their understanding. Asking questions may be seen as challenging, confusing, and lacking confidence. I think sometimes when people ask questions, that's just because they want to know information and just receive it that way. Um, I think people don't want to feel checked, and that's I don't know. I think oftentimes I feel like I have to ask less questions because the provider feels like they are being attacked, and so that I wish that they could work on that. Aggressive behavior stereotypes harms BIPOC with undiagnosed neurodivergence. Yeah, I think it's just a little harder if you're a dude, especially a black and brown dude, undiagnosed. You're oftentimes labeled with as more aggressive, and being labeled as more aggressive, that has a stereotype. Um, that's it's going to be weaponized against you, and it just makes it harder to ask for help. I hate that feeling like I have to behave just to be in a certain environment. And then in public health, need for critical review of how neurodivergent is included in public health practices. Um, and then The NIH has not formally integrated neurodivergence into this endemic framework, but it definitely is a social determinant of health. Um, and the current administration is spreading misinformation about people with disabilities, increasing stigma and barriers. They're over here asking me to sign up to a registry, which is weird. And we're like losing so much progress. And like I said, they're using Tylenol as a distraction for what's happening with the ice raids. There's, it's it's ludicrous. Um, people who are autistic, just because they're autistic doesn't mean that they're not out here having sex. I'm very much a living example of that. When I get and when people are rejected, um, they can sometimes become hypersexualized. I've been rushed out of an HIV testing session um, because I was fidgeting, and they thought that I was nervous about my test results, and that's unfair. Um, and so I'm not gonna have the conversation with them about like, hey, I'm actually fidgeting. I just want to just be try and calm down as much as possible, and not look and just look as normal as possible. Um, and my goal is always to blend in. But I think people who are autistic, oftentimes are impacted still. And Yeah, I think when I'm hypersexualized and I'm manic, oftentimes I am out there not using a condom. I'm out there having sex and using drugs at the same time. Um, I think it's just something that I've done when I am off track. Um, so yeah, I think it's something to consider. Just because people are, just because people have conditions doesn't mean that they um, don't have. Yeah, I mean, it's just I don't know. I think it should be it should be a no-brainer, but for some reason, um, you know, these sexual health marketing messages are only tailored at the club, for attractive, thinner dudes, and it kind of sucks that like sometimes when I think of the neurodivergent community being neglected in that aspect, um, it makes me consider like how often do they get tested? Um, and so yeah, um, I think I would like to see a little bit more examples of that. Guidance and capacity for outreach. I think it's very understanding to know that like people who have sensory processing um, issues, they not and that's not just autism. People who deal with sensory issues, like they're not going to be at the bar at the club all the time. They may be there sometimes. I know I do. I go sometimes. Um, and so I think that that's something to consider. Like, where are we doing outreach for the neurodivergent community? Um, and so, can it be more inclusive? So review an inclusive outreach, and then acknowledge the diversity of neurodivergent experience. Um, I think that oftentimes when I do consider people who are neurodivergent, um, I know that when I became a QIDP, I did see that about 90% of people who are with disabilities, 90, about 90% of them reported abuse, whether it was financial, sexual, um, some form of abuse. So I think it's important to have to be trauma informed, that this community um, is a lot more vulnerable in that aspect. And then adapting messages and services for broader accessibility. Um, just knowing that they may not see your message if it's at the club, put it on Twitch, put it on Discord, put it on. I think that there's many other avenues. And then training of staff. Um, there's equipment. You could equip staff to just be a little bit more understanding of this. I think sometimes we train staff to be very bubbly, or to do when we do risk assessment, we try to see we gauge their body language, and so I think kind of like I said, the fidgeting and somebody rushing a session could be based off of, oh, we think that they are nervous about their testing session, but in reality, they're stimming. And stimming has nothing to do with whether they're nervous, whether they're scared, whether they're trying to get out. That's actually them just self-soothing. And if you know that self-soothing is completely normal to the neurodivergent community, people who are autistic, many people who aren't autistic, I think that that's something that will allow you to just build rapport. It would allow a session to just flow. And then emphasizing affirming communication style, doing just that. Um, Providing examples of inclusive practices in healthcare setting. Um, I think, employing someone like me, um, I think I'm almost employed here for 4 years now. And this is the first time I've ever held a job for 4 years. It's the longest time I've ever held a job. Um, so that's a huge like accomplishment. Like I said, like people are oftentimes unemployed, or can't hold a job. It's hard. Um, we oftentimes get sick. And so yeah, I think it's it's crazy. I think before this, the longest I held a job was like a whole year. So I think Calor has been able to kind of transform my life, in a wild way. And then foster an environment of empathy and non-judgment. People need to know that they can open up. Um, they may not know what diagnosis they have. Kind of like how I said, I am not an expert of autism, but you know, I can at least tell you I was diagnosed, and that person may have more knowledge of autism, and they could just, ease up me. So I wear this lanyard, which is something that lets people know that I have a hidden disability, um, and it kind of just helps people understand that I may need a little bit more assistance or a little bit more time. Okay, the screening for disabilities, which I've just talked about, the hidden disability sunflower. And then the tools and measurements, we could start doing surveys for for in our at our offices. These aren't things that exist yet, but these are things that we should be implementing ourselves. We need to be creating it ourselves. How safe did you feel? These are things that I'm also creating myself, and I have a research background, and so I'm going to be pumping some of this stuff out myself, to figure out how we can make our organizations a little bit more inclusive based off of a report card. Okay, sorry for going 9 minutes over, but there we go.
Thank you so much, Edgar, for that amazing presentation, and thank you for all the love in the chat. This is definitely a must-have conversation, and I'm very, very happy for you to see you lead it. There was a comment. I know that we are 9 minutes over, but there was an additional comment that I wanted to bring up from John, that he mentioned that some of the biggest barriers faced were having a family that did not believe in ADHD/autism and not having access to services that fit me best until my mid-20s, and that he appreciates your presentation.
Um,
And I think that for me, one of the biggest highlights from your presentation, and I think this is just a start from many conversations that I hope to have with you, is about the intersections in terms of HIV, neurodiversity, acting services, being Latino, being a person of color, and how all of those identities become even more and more barriers and more challenges for people accessing services, right? And if we're thinking about ending the HIV epidemic, soon, anytime soon, we do have to consider all of these variables and all of the diversity that is within the diversity of our community. So again, Edgar, thank you so much for your time for this presentation. I apologize that we don't have much time for Q&A, but I did put Edgar's email if you want to reach out. There's also on the screen you can scan the QR code so you can engage with Edgar and keep the conversation going. This webinar will also be posted on NMAC's YouTube channel. I put it on the link on the chat. And again, thank you everyone very, very, very much. And again, thank you so much, Edgar, for your expertise, for your time, for putting this presentation together.
Thank you so much for the opportunity, and we have much more to discuss in the future. And I I I'm happy that this is a continued conversation that doesn't really end. It shouldn't. Um, it impacts many people. That it's not just an autism thing. And yeah, so thank you so much for the opportunity, and we'll chat again.
Amazing. Thank you. Thank you again so much. And this is just a start. And again, I think we should be having as a movement this conversation a lot more. So I'm happy to support you in doing that and NMAC supporting you in supporting having this conversation. So thank you all very much, and we'll see you next time. Ciao everyone.
All right. Bye. Thank you.